Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board-certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast. Christina, you use a jugular blood sample to provide a clot in the deficit. Would a bone graft be contraindicated? And a couple other people asked this question as well. The blood clot is a bone graft, and it's free. And I did misspeak when I recorded that portion, and I said it was a mandibular sample. It's not a mandibular sample, although a lot of times we'll have enough bleeding because the mandibular artery is mistaken for part of a cyst, and we'll nick that. And so we may get some bleeding from that. But for the most part, the jugular sample is required because if we just put in a hole that big, if we just put that bioglass, or if we just put Synergy in there, which is bicalcium phosphate and hydroxyapatite, then it's dry, and so we want to have some blood clot in there, even if we are going to use a bone graft. But there's no reason really to use anything but a blood clot, because a blood clot's a perfectly good bone graft, unless we're trying to augment the bone height on a tooth adjacent to where we're placing that blood clot or leaving the blood clot. And we go over that in another case. Francis, good question. Can a tooth that's not erupted form a cyst, or a tooth root form a cyst? And the answer to that is yes. They are not called dentigerous cysts. They're usually referred to as radicular cysts. Radicular cysts. That's a ridiculous thing to try to say together. But a radicular cyst, meaning of the root. And so those can happen, and they're formed from the same cells. They're the epithelial cells of Malassez, which are in the periodontal ligament space as remnants of the root sheath called Hertwig's epithelial root sheath that surrounds the crown and is raked off as that tooth comes through the marginal bone and erupts in normal eruption. But even if a tooth erupts normally, those cells, which are the same cells that form the dentigerous cysts, are the same cells that there's going to be some remnants of those in the periodontal ligament space. And so those cells can become cystic or proliferate and form cysts, even though there's no unerupted tooth. The fact that a tooth is unerupted, there's a ton of those cells down in there, and so they are very likely to form a cyst, because that cell layer surrounds the entire crown, and when that doesn't erupt, normally, like I just said, it's raked off the crown. It becomes part of the junctional epithelium, which is where you place your periodontal probe in a normal tooth pocket. And if it doesn't, then all those cells are under the bone, and all of them secrete fluid and have a tendency to form those cysts. So hope I didn't bore you or make it such that you now don't understand before you did. But great question, Mary. Do you know the percentage of unerupted tooth that form cysts? Probably more than don't. We do see some that are older patients that have that, especially that first premolar that has not erupted, where there's no evidence of a cyst at all, either unilateral or bilateral. But if the dog is a small breed dog, if it's brachycephalic, in general, large or small, and that first premolar is missing, there's a really good chance that there's an unerupted tooth there. And in those categories, small breed, brachycephalic boxers, as you saw with Boris, and brachycephalics in general, there's a really good chance that they're going to have cysts that form there. So be using that as a criteria in your exam room. And look at all your patients. I don't care how old they are. Look at them all when you bring them in for the examinations. You're going to find a lot that don't have that tooth. And when you start looking, you're going to find a lot of cysts if you haven't been looking before. Especially if you've just gotten dental radiography in your practice. You've got them waiting there for you to find, I guarantee you. So you want to start looking for those. And that's not an easy place to look, especially in a boxer, because you've got that huge boat paddle of a tongue that you literally have to move out of the way in order to see where that tooth was. Because they're panting, they're doing the boxer wiggle, and they're not going to usually be still. They're usually very happy, but they wiggle a lot. And that tongue is just out there just covering that area. So you've got to almost take and move it with your hand out of the way to be able to see if that tooth's there. And sometimes you can't. Sometimes you can't visualize it well enough to see it. But a lot of those boxers don't have that first premolar, and we get a lot of them that have that. Now, not to say that you can't have that in other places and in other large breed dogs, because we do get that. One common scenario is in dogs that are particularly rambunctious when they're puppies, and they maybe injure that tooth and it doesn't erupt, or it's impaled up into the maxilla and doesn't erupt, and we're left with a tooth that is just missing. And those can definitely form cysts, and we've seen several of those that have gone right through the nasal bone and affected the whole nasal cavity with a cyst and gone back caudally suborbital. So those can be particularly damaging. And in the maxilla, you don't have all that thick bone that's there to impede the expansion of that cyst. And so it's more likely to be more invasive more quickly in the maxilla than it is the mandible. Plus, you have all the sinus cavities that superimpose themselves and make it almost impossible to tell what's cyst and what's not radiographically. So those are all referrals. Never think about doing a maxillary cyst ever in your practice, because those are all referrals. They can be very invasive. The ones in the mandible, the ones that I showed you with Boris, unless you're really good at surgical extractions, you should not be attempting to do those either, because it takes a lot of skill to get all the cyst material out. Sometimes you're working blindly. Sometimes the mandibular canal is open and the neurovascular bundle is exposed. Sometimes that cavitates in the mandibular bone and forms caverns or caves that you have to literally explore and go back into. So unless it's a small area around one of those and you catch it early, you probably want to refer these unless you're really skilled at doing your surgical extractions. And if you had maybe some lesser ones that you've done successfully that are like this, or not quite like that, I would never recommend you try Boris's case, but some that are maybe 25% as involved as that. What can be done for patients with hyperplasia where referral is not an option? Really, there's not much that you can do or can't do that's going to change the course of those. The body may form tertiary dentin on those in some cases if they're not deep. Some of those are diseased soft enamel that's actually still covering the dentin. So that being said, those areas are going to form calculus really quick. And there's 42 teeth in that mouth. So if all the teeth are affected, there's going to be changes at some point. So you need to really relay that to the owner so these pets don't suffer for their lives in silence. They need to be evaluated at some point. If nothing else, they need to be brought in. If you get them coming in at 6 to 10 months of age, get them in 6 to 8 months, re-radiograph them, and you'll see whether the tooth is growing and maturing, or whether it's already starting, or it's already dead. There's really no in between those. I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.